Every 4 minutes, someone in this country is handed a new prescription that will quietly start working against their memory. Most of them will never be told. By the time this video ends, dozens more will have picked up that bottle from the pharmacy counter, thanked the pharmacist, and walked out believing it is helping them. For some, it is. For others, it is the beginning of a fog that their family will one day mistake for old age. I'm Dr. Lumiva. After years of watching patients and their families sit across from me, trying to understand why a sharp, capable person suddenly can't hold a thought, I can tell you this. The answer is almost never, it's just aging. Age doesn't erase a person overnight. Something else usually does. And more often than anyone wants to admit, that something is sitting in a medicine cabinet, doing exactly what it was prescribed to do, while doing something else entirely, unnoticed. Today, I am walking you through 9 medications that the newest research keeps tying to a faster, sharper decline in memory and thinking in older adults. Some of these are prescription only. Some you can buy off an open shelf for a few dollars without anyone asking a single question. We will count down from the one that gets overlooked the most to the one I consider the most dangerous of all because it isn't even a single drug. Watch for number 3. It is one of the most commonly prescribed medications in the world. It looks completely unrelated to memory, and the newer data on it should worry you. Before we start, tell me in the comments how old you are and which of these medications, if any, you or someone you love takes every day. I read every comment, and it genuinely shapes what I cover in future videos. Now let's begin at number 9. Number 9 is Diphenhydramine, sold under the name Benadryl. Don't let its position at the bottom of this list fool you. This is one of the most widely used drugs in America, and it is sitting in almost every household right now. People reach for it to fall asleep, to calm a seasonal allergy, or to take the edge off a cold. It costs a few dollars, it sits on an open shelf next to the candy, and the cough drops. And because nobody needs a prescription for it, most people assume it must be gentle. Inside an aging brain, it is doing something far more aggressive than the label suggests. Diphenhydramine belongs to a class of drugs called anticholinergics. That is a long word for a simple idea. These drugs block a brain chemical called acetylcholine. Acetylcholine is the messenger your brain relies on to lay down new memories and to stay alert through the day. As we get older, the brain naturally produces less of it and leans harder on what little remains. A drug that blocks that chemical lands far heavier on a 70-year-old brain than it ever would on a 30-year-old one. The structure that absorbs most of the damage is the hippocampus, the small seahorse-shaped region where short-term memories are formed before they get filed away for the long term. In practice, I have watched patients take a nightly antihistamine for years, slowly lose their sharpness, and never once connect the fog to the pink pill on the nightstand. Researchers at the University of Washington followed thousands of older adults for close to a decade and tracked their use of strong anticholinergic drugs, diphenhydramine included, against pharmacy records rather than memory or self-report. Published in JAMA Internal Medicine, the study found that people with the highest cumulative use of these drugs carried a substantially higher risk of developing dementia than those who avoided them, and the effect did not fully reverse when the drug was stopped. That detail is the one that should stop you. This isn't only about how foggy you feel tomorrow morning. It's about what years of quiet, steady use may leave behind. Here's what to do. Read the label on anything you take to sleep and on anything marked PM, nighttime, or allergy relief, because those are very often just diphenhydramine wearing a different name. If you take it for allergies, newer antihistamines like loratadine or cetirizine do not cross into the brain the same way and are considered far gentler choices for long-term use. Never stop a medication on your own initiative. Bring it to your doctor, but stop assuming that because something sits on an open shelf, it is automatically safe for your memory. That is number 9. Number 8. Number 8 is one your bladder is grateful for, and your brain silently pays the bill. Oxybutynin, sold as Ditropan. This one is prescribed to seniors dealing with a sudden, urgent need to reach the bathroom. The kind of overactive bladder that can reshape an entire day around knowing where the nearest restroom is. The relief Oxybutynin provides is real. The embarrassment it spares people is real too. But oxybutynin works by blocking acetylcholine, the same chemical Benadryl blocks, and it crosses into the brain with unusual ease, settling in right where new memories are formed. That makes it one of the more concerning medications on this entire list, especially when it's taken month after month, year after year. A large study of adults over 65 who use strong anticholinergic medications like Oxybutynin for more than a year found their dementia risk was clearly higher than in non-users, and the longer the exposure, the steeper that risk climbed. What troubles me most about this particular medication is how easily it slips past the conversation. Patients are told a pill will calm the bladder. Almost nobody mentions that it may be dimming the mind at the same time. The fog gets blamed on getting older. People describe misplacing their keys, forgetting a name mid-sentence, losing the thread of a conversation they were just having, and everyone around them nods and says, "Well, you're not as young as you used to be." It is rarely traced back to the small daily pill until real ground has already been lost. If you take Oxybutynin and you've noticed your memory slipping, take that seriously, because you should not have to choose between your bladder and your brain. Newer medications like Mirabegron, sold as Mirabetril, work through a completely different pathway that doesn't touch acetylcholine at all. For most older adults, they offer similar control with far less cost to thinking. Bring it up at your next appointment. Number 7. Number 7 is one of the most widely prescribed families of medicine on the planet, and it earns its place here for a reason most people never hear about: the proton pump inhibitors. The big names are omeprazole, sold as Prilosec, and esomeprazole, sold as Nexium. These drugs shut down acid production in the stomach and get handed out for heartburn, reflux, and that burning feeling after a heavy meal. People often stay on them for years, sometimes decades, because the moment they stop, the old symptoms come roaring back. That rebound makes the drug feel indispensable, like the only thing holding the line. Here's the part almost nobody hears at the pharmacy counter. Your stomach needs acid to pull certain nutrients out of your food, and chief among them is vitamin B12, which protects the wiring of your nerves and your brain. Turn the acid down far enough for long enough, and B12 drops, often without anyone checking. So do magnesium and calcium, 2 minerals your brain cells depend on to fire cleanly. Starve the neurons of those, and you get the kind of misfires, confusion, and memory slips that can look remarkably like early dementia, when the real driver is a nutrient deficiency your own medication has been causing all along. Some large observational studies following older adults on regular PPI use have reported a meaningfully higher rate of dementia diagnoses compared with people who stayed off them, and researchers have separately found that PPIs may raise levels of amyloid beta in the brain, the same sticky protein implicated in Alzheimer's disease. It's worth saying clearly, this research is still debated, and later studies haven't all agreed on the size of the effect. But the nutrient depletion pathway alone is reason enough to take a hard look at long-term use. If you take a PPI every single day, that's a conversation worth having with your doctor. Many people can taper down to a gentler class called H2 blockers, like famotidine, sold as Pepcid, which carries far less of this risk. Deglycyrrhizinated licorice, a natural compound that coats and calms the stomach lining, can also ease symptoms for some people with no cost to the brain at all. The goal is always the lowest dose for the shortest time that actually controls your symptoms, not a pill taken forever out of habit. Number 6. Number 6 is prescribed for a problem most people would rather not discuss out loud, and it deserves far more caution than it usually gets: opioid pain medication, drugs like tramadol, oxycodone, and hydrocodone. These are given to seniors managing chronic back pain, arthritis, or recovery after surgery. And for genuine, severe pain, they can be the difference between a livable day and an unbearable one. Nobody is disputing that pain deserves to be treated. What gets left out of the conversation is what long-term opioid use does to an aging brain. Opioids act directly on the central nervous system, and in older adults, they are strongly linked to sedation, slowed processing speed, and impaired attention, effects that tend to be far more pronounced than in younger patients because aging kidneys and livers clear the drugs more slowly, letting them build up in the system. Chronic opioid users in multiple studies have shown higher rates of cognitive impairment and a faster rate of decline on memory testing than matched patients managing similar pain without opioids. Falls also climb sharply on these medications, and a fall with a head injury can itself trigger a rapid cognitive decline that's easy to blame on getting older, rather than on the fall or the drug that caused it. The layered danger here is that pain itself, when poorly controlled, also damages cognition and mood. So this isn't a case for suffering through pain untreated. It's a case for making sure opioids are being used at the lowest effective dose for the shortest reasonable time, with regular reassessment, and with non-drug pain strategies like physical therapy, targeted exercise, and non-opioid medications explored alongside them. If you or someone you love has been on a steady opioid regimen for months or years and you've noticed slower thinking, more confusion, or more falls, raise it with your doctor soon, not something to wait out. Quick pause here. If this is helping you connect some dots, take 1 second and tap that like button. It genuinely helps this information reach more families who need to see it. And while you're there, tell me how many prescriptions you or your parents are currently managing. I read every single comment. Now, back to the countdown. Number 5. Number 5 is the benzodiazepines. Lorazepam sold as Ativan, diazepam sold as Valium, alprazolam sold as Xanax. These sit among the most commonly prescribed medications in the country for anxiety and sleep problems, and they work by boosting GABA, the brain's natural calming signal that turns down an overactive nervous system. At first, they can feel like a rescue. The panic eases, the racing thoughts slow down. Sleep finally comes after months of lying awake at 3 in the morning. But over time, the picture changes. A well-known study published in the British Medical Journal followed thousands of older adults for several years and found that those who used benzodiazepines for longer than a few months carried a notably higher risk of an Alzheimer's diagnosis than those who never used them or used them only briefly. Longer-acting versions, like diazepam, appeared to carry even more risk because they linger in the body and accumulate in fatty tissue, including the brain itself. It's important to say plainly that this research has real critics. Some scientists argue that people who are already developing early, undiagnosed dementia are more likely to be prescribed a sedative for the anxiety and restlessness that dementia itself can cause, which would make the drug look guilty when it isn't the true cause. That debate is unresolved. What isn't in serious dispute is the day-to-day effect these drugs have on an aging brain while you're taking them. Learning becomes slower. Mental flexibility drops. Many people describe a flatness, a sense of moving through fog, of no longer feeling entirely like themselves. The cruelest part is the exit. If a benzodiazepine is stopped abruptly after long-term use, anxiety and insomnia can return far worse than before, along with agitation that can become truly dangerous, including a real risk of seizures. That makes the medication feel indispensable at exactly the moment it may be doing the most harm. So here's the rule, and it matters. If you've been taking a benzodiazepine for more than a few weeks, do not stop suddenly. Work with your doctor to taper gradually over weeks or months, not days. There are gentler alternatives worth discussing, including buspirone for anxiety, which doesn't carry the same sedation, and specialized forms of talk therapy built specifically for insomnia and anxiety that can restore calm without the cognitive cost. Number 4. Number 4 is a single medication prescribed for 3 completely different problems, and it carries one of the heaviest hidden burdens on this entire list: Amitriptyline, sold as Elavil. It's an older antidepressant still widely prescribed today, not usually for depression anymore, but for nerve pain, sleep difficulty, and migraine prevention. That versatility is exactly why it stayed so common. It looks like a medication that can do a little bit of everything. Underneath that reputation, it is one of the most powerfully anticholinergic drugs still in common use, meaning it blocks acetylcholine, the very chemical your neurons rely on to communicate and to store new memories, and it does so aggressively. The University of Washington research mentioned earlier followed thousands of adults over 65 and found that those with the highest cumulative exposure to strong anticholinergic drugs over a 10-year period, amitriptyline prominently among them, carried a sharply higher risk of developing dementia, and most of those patients were never told the medication could do that. They were given it for sleep or for nerve pain. Gradually noticed words slipping away, memory thinning, concentration weakening, and simply assumed it was part of getting older. It doesn't take a high dose to cause this. A small nightly dose taken for years can slowly erode cognitive function with no obvious warning sign until the loss becomes significant enough that a family finally brings it up at an appointment. If you or someone you love takes amitriptyline, that's worth bringing up soon. For nerve pain, options like duloxetine or gabapentin can offer similar relief without the same anticholinergic weight. For sleep, melatonin or a very low dose of a gentler alternative may help. For mood, newer antidepressants such as sertraline or escitalopram are generally considered far kinder to long-term brain health. Number 3. This is the one I told you to watch for, because it's prescribed to millions of people for something that sounds completely harmless. Number 3 is paroxetine, sold as Paxil. It belongs to a family of antidepressants called SSRIs, used widely for both depression and anxiety. And on the surface, it looks like a modern, gentle option, far kinder than the older psychiatric medications we grew up hearing about. But here's the detail that almost never comes up. Paroxetine is the one SSRI with meaningfully strong anticholinergic activity. That single trait sets it apart from close relatives like sertraline and escitalopram, and it means paroxetine is affecting the exact same acetylcholine system that every other medication on this list has been disrupting. Because of this, and because older adults process the drug more slowly, paroxetine has been flagged repeatedly in geriatric pharmacology literature for its cognitive burden. It is included on the American Geriatric Society's Beers criteria, a formal, widely used list of medications considered potentially inappropriate for older adults, specifically because of risks like this one. There is a painful irony sitting inside that fact. The medication is prescribed to help stabilize the mind, and yet over years of use, it may be quietly working against the very clarity it was meant to protect. The solution here is fairly direct. In older adults, paroxetine is generally a medication worth avoiding when alternatives are available, and alternatives usually are. If you take it, speak with your doctor about switching to sertraline or escitalopram, which are considered gentler on this particular pathway and do not carry the same anticholinergic concerns. Supporting healthy levels of B vitamins, especially B12 and B6, may also help support mood as these changes are made. Number 2. Number 2 is prescribed so subtly that many people taking it don't fully realize what type of medication it actually is. Antipsychotic medication, drugs like quetiapine, sold as Seroquel, risperidone, sold as Risperdal, and olanzapine, sold as Zyprexa. This one concerns me deeply because a large number of people taking these drugs never knowingly agreed to take an antipsychotic. These medications were developed and approved for serious psychiatric conditions like schizophrenia and bipolar disorder. Today, they are frequently prescribed off-label to older adults for sleep problems, restlessness, or the agitation that can come with dementia itself. Powerful drugs built for severe psychiatric illness are now routinely used in homes and care facilities to manage seniors who are simply confused, restless, or difficult for an overwhelmed caregiver to settle. The cost of this can be severe. Regulatory agencies, including the FDA, have issued a black box warning, their strongest possible caution, stating that antipsychotic use in older adults with dementia is associated with an increased risk of death, largely from cardiovascular events and infections. Beyond that mortality risk, these drugs work by suppressing dopamine, a chemical involved not only in mood, but in focus, planning, and memory formation. Reduce dopamine enough, and the brain becomes slower and less responsive. That is part of why some people on these medications appear flat, distant, or almost absent, while their families quietly grieve the disappearance of someone who is still physically sitting right in front of them. If you or a loved one is on one of these medications, the first step is a direct question to the prescribing physician. Why was this started, and is it still truly necessary, or is it being used mainly for convenience? Many behavioral symptoms in older adults, especially those with dementia, can be improved without medication at all, through consistent routines, reduced noise and overstimulation, treating hidden sources of pain, and better sleep and lighting management. When medication truly is required, the lowest effective dose for the shortest possible time is the goal, always under close medical supervision. Far too often, families are simply never told what these drugs can do, and they watch a decline they believe is just aging, when the true driver may be chemical. Number 1. Now we arrive at number 1, and it isn't a single medication at all. It may be the biggest hidden driver behind every single story I've told you today. Number 1 is anticholinergic polypharmacy, the danger almost nobody talks about, and quite possibly one of the leading causes of medication-driven memory loss in older adults. You were probably expecting one final villain, one single worst pill. The reality is more subtle, and honestly more common than any single drug on this list. The greatest danger often isn't one strong medication. It's the slow accumulation of several mild to moderate anticholinergic medications taken together, while nobody adds up the total burden. Polypharmacy simply means taking many medications at once, something extremely common in older adults managing several chronic conditions. Anticholinergic burden refers to the combined effect of all of those medications blocking the same memory-related chemical simultaneously. Picture a very ordinary scenario. A senior takes diphenhydramine every night for sleep, oxybutynin every day for bladder control, and a low dose of amitriptyline for nerve pain. Individually, each medication might produce only a small, barely noticeable effect. Together, those effects stack, and the total burden on the brain rises far faster than any single prescription would suggest. Researchers use tools like the Anticholinergic Cognitive Burden Scale specifically because this stacking effect is so easy to miss when doctors, specialists, and pharmacies aren't all looking at the full list together. Large population studies tracking older adults with the highest total anticholinergic burden have found dementia risk climbing sharply compared with those carrying little to no burden. And the overwhelming majority of these patients had no idea they were even taking anticholinergic medications in the first place. No one had ever explained it to them because no single doctor was looking at the whole picture. When acetylcholine is blocked from several directions at once, the brain doesn't simply slow down. Neurons can begin to weaken from underuse, connections can shrink, and the brain can settle into a quiet, underpowered state that can look remarkably similar to early Alzheimer's disease on cognitive testing, even when the true cause is chemical rather than degenerative. Here is the hopeful part, and it's the entire reason I made this video. Medication-driven cognitive decline is frequently reversible when it's caught early. Reduce the burden, and many people regain real clarity, energy, and memory within weeks or months, not years. The brain is more resilient than most people realize, but only once the source of the harm is actually removed. The solution doesn't require a miracle. It requires a careful medication review. Sit down with your doctor or your pharmacist and go through every prescription, every over-the-counter product, and every supplement you take, all in one conversation, not scattered across different specialists who never talk to each other. Add up the total anticholinergic burden. Simple scoring tools exist specifically to help identify that risk. Once the problematic medications are identified, unnecessary ones can be reduced or discontinued under proper medical supervision, safer alternatives can be introduced where needed, and the brain can finally be given a real chance to recover. This may be the single most preventable threat to the aging brain on this entire list, and that is exactly why it earns the #1 spot. Now I want to hear from you. Of these 9, which ones are currently sitting in your medicine cabinet or your parents'? Have you noticed brain fog or increasing forgetfulness after starting a new medication? Tell me in the comments below, and tell me that you'll ask for a full medication review this week. Your comment might be the exact thing that helps the next person reading it make that same call for someone they love. And before you go, there's one more place your body hides its warnings without a sound. Your medicine cabinet is one place. Your fingernails are another. They can reveal warning signs involving your kidneys, your blood, and even your nervous system years before other symptoms ever show up, and most people never learn what to look for. That's the topic of the next video. I'll show you the exact signs worth checking tonight. I'm Dr. Lumiva. Stay sharp, and I'll see you there.